diseases. So what she's experiencing here is something that we're seen in a whole lot of areas, and why that is really requires further investigation.
For me, training as a gynaecologist, we were taught that women were unreliable historians, meaning that you couldn't necessarily believe what they were saying. One of the consequences of that has been for a common condition, for example, such as heavy menstrual bleeding, where what the woman described wasn't the diagnostic criteria. So the diagnosis, and this is the case with several conditions in women, on so-called objective criteria rather than on what the woman says. And the fundamental basis of that is that the woman can't be expected to necessarily report things accurately.
Martha, please tell me that advice is still not being given out in medical school today.
Due to the advocacy of some fantastic people around the world, we now have heavy menstrual bleeding diagnosed as what the woman says.
Martha, we were speaking a moment ago about the historical and structural issues that have contributed to this gender bias. What have the implications been? Are you able to give examples on what it's meant for understanding drug dosages or side effects of medicines in women, or even just understanding how well drugs work in women?
I think, as Robin said, there's been a start. So the NHMRC, for example, that's our major government funding body, now indicate that you have to have equal numbers of males and females in your research unless you're studying something which only applies to one or the other. But there's no extra funding available for doing that work. In terms of drugs, I think we just haven't even started yet.
Yeah.
Robin?
So just Martha, I think absolutely right with the NHMRC. I think they're leading the way in Australia. But some of the work we're currently doing at the moment is reaching out not just to the funding agencies, which are important, reaching out to what's happening in medical journals, what's happening in the training. And I think we are finding that there's still very much a lack of understanding of the importance, not so much of including women in studies and research, but disaggregation of data is still not routine. So there's still a long way to go if we're going to change the way people think about what is best practice medicine. I think we've got a long way to go in Australia yet. Understanding the differences between men and women is the easiest form of precision medicine, which I think many people would recognise we need to move towards.
That's right.
And back to what you were saying, Martha, about the recognition of heavy menstrual bleeding, have added the attitudes of doctors and nurses in the clinical setting. Has that changed much overall from what it was previously when you were training?
Look, that's a long time ago, and fortunately things have moved on. But one of the big changes has been the increased number of women who are providers of care. And just to make the point, when we're thinking about health, sex differences in health, is there's a growing body of evidence that women as doctors provide better care, meaning that they provide more evidence-based care, their surgical complication rate is lower, and their likelihood of following evidence-based protocols in an emergency setting is higher. So that's just turning things around. We've got more women doctors, still not enough at senior levels, but our healthcare is improving because of that.
Well, one area where there seems to be a lot of research lacking in women is exercise science. You may be wondering why that matters, but let's take, for example, concussion in sport. There are differences in how men and women experience concussion, and it's critical that we understand these differences if we're going to keep athletes safe. Dr. Mandy Hagstrom is an exercise scientist from the University of New South Wales and one of this year's ABC Top 5 scientists.
So my research looks at the different ways that males and females respond to exercise. And I did it because I was trying to train myself, and a lot of the literature I found just didn't relate to me. So I wanted to know, am I different and would I respond differently?
So you as a sports person, and you felt like there wasn't what you needed to get the best performance from yourself?
Yeah, absolutely. Me as a sports person. The majority of the literature still focuses on men. So a recent analysis from our team in a small subset area demonstrated that male participants outnumbered females on a ratio of 5-1. So there were 400 males and only 80 females. So it's really hard for us to understand what's going on when we don't have the data.
People differ in a lot of different ways. Why is sex or gender, and we can get to that in a second, a factor that should be representative?
Well, we're biologically different. So there's some obvious ones. For example, stature. Males are bigger. Because they're bigger, they've got more overall muscle mass and they've got bigger lungs. So things like that make sense that they would influence exercise capacity. But there are things that are less obvious as well. So women tend to take longer to recover from muscle damaging exercise. And women also appear to have less fatigable skeletal muscle. So things that we can't see actually affect how we should be prescribing exercise.
What do we know about how sex hormones interact with exercise?
We know a bit. The more we know, the more we realise we probably don't know. So for years, it was thought that testosterone was, the biggest driver of muscle growth. And now we actually know that that's not, in fact, the case. So I think there's still a lot of work to be done, particularly in female or women's hormones across the lifespan. So we know very little about what happens with menopause and how the hormones will influence things like muscle growth. And we know very little about hormone replacement therapy and how it will affect muscle growth.
So some of the other things that we've discussed on the health report before have been around, women are more likely to die from a heart attack than a man because they're not well understood. Why is exercise science, which generally isn't a life or death thing, why is this an important place to put research effort?
Good question. So it's not imminent life or death, but exercise does contribute to quality of life and also mortality. So it's fundamentally important because our health and well-being, and mental as well as physical, is influenced by exercise and how we perform that exercise. So if we only understand how exercise influences the male body and male health, we're potentially missing some really important things that could improve females' quality of life. Conversely, understanding the female adaptations or the female response more will also help us improve our understanding of prescribing exercise for males. So it's a win-win situation.
Are there harms that have come out for women because of this lack of understanding?
Yeah, so there's some really fascinating research that's has only come out in the last few weeks and few months, and it's around concussion in women. And it's really fascinating because concussion in a sport context had historically been studied in men because of sports such as rugby and rugby league, contact sports being predominantly participated in by a male audience. But we know the female participation in these sports or women participation is growing rapidly. And what has been shown is that the mechanisms of concussion in males and females differ. So the way that we can prevent concussion might not be the same between sexes.
That's Dr. Mandy Hagstrom, exercise scientist from the University of New South Wales. We're joined by Professor of Obstetrics and Gynecology at the University of Melbourne and at the Royal Women's Hospital, Martha Hickey, and as well as Professor Robin Norton, who's the Principal Director at the George Institute for Global Health and is also with the University of New South Wales. So as we've heard, Mandy just spoke about an area of research where the data on women is simply just lacking. Martha, are there any other examples you can think of?
Look, I think most areas of health really have not been explored adequately for the sex differences that they might have. And then gender differences is a whole other area that really we've hardly even started to look into. So I think most systems in our bodies differ between males and females from a cell level all the way up through to clinical research.
Robin, did you want to add anything about that?
I think an important issue that we should consider is the funding that's available for research on conditions that particularly affect women compared to those that particularly affect men. Again, some recent research that's just been published has shown that in nearly 3/4 of the cases of NIH funding over the last few years, where a disease primarily affects one gender, then it's more likely the funding pattern favours males, and that if a disease affects more women, it's more likely to be underfunded, or if the disease affects more men, it's more likely to be overfunded. So I think this is something that we need to explore further and see whether indeed this is the case also in Australia.
And we know that there are some really complex conditions that disproportionately affect women, such as Alzheimer's disease, autoimmune diseases like multiple sclerosis. You mentioned there the funding issue, but you also were speaking before about precision medicine. Are these biological sex differences something that we need to understand better to achieve precision medicine and, really get the best options for women's care?
Absolutely. And I think it comes back to some of the issues you were raising before about the differential effects of some pharmaceuticals on women compared to women. And Martha alluded to this before. We do need to understand this more precisely. So again, recent research that's just been published in the last couple of months has shown very clearly that women experience adverse drug reactions nearly twice as often as men, yet the role of sex as a biological factor in the generation of adverse drug reactions is poorly understood.
So that's drugs. What about medical devices, Robin?
Well, medical devices generally is an area which is, if you like, poorly examined. The testing that's required for medical devices is nowhere near as stringent as the testing that we'd use for pharmaceuticals. And I think there have been a number of examples where medical devices have been shown to pose greater risks for women compared to men.
Which devices?
Well, one example is that the majority of artificial hearts are made in a standard size, which is too large for many women. Another example that colleagues at Macquarie University have recently published and spoken about is the issue of hip implants, twice as likely to fail in women compared to men.
Martha?
Yeah, really interesting. Just to sort of stand back again from this and say that science is only as good as the question that you ask. And what guides the question will be your sex and your gender, amongst other things. As a researcher, women ask different questions than men. And the issues that Robin is just raising, I completely agree with, around funding, for example. We need to have more women at a senior level who are asking the questions and who are assessing the grants and allocating the funding, because that will help us to get around this issue of differential funding towards conditions that affect men.
So we're really hearing that there's a lack of consideration for sex and gender that is limiting our understanding of how women experience illness and injury, and not having that complete picture can have huge implications. So let's actually talk about what's being done to fix the problems and what should be done. Robin, is it as simple as just having more women in research, or is there more that needs to be done at that research level to correct this gap?
I think certainly having more women at senior levels is going to be very important. But a major piece of work that we and many others in the country are working on it is really looking at the policies that we have across the medical research pipeline in terms of, is it a requirement, or are people encouraged, or is there training to ensure that research is undertaken such that appropriate numbers of men and women are included in research, but then data are analysed and reported separately for men and women. So we start to understand the biological and the gender factors that play important roles in health outcomes.
What about at the clinician level, Martha?
I think that it's clear that at a clinician level that women are disadvantaged when it comes to the kind of conditions that affect both men and women, because we just don't have the understanding or the knowledge base to know how women might present differently with their condition and respond to treatment.
Martha, what advice would you give to women who've seen a doctor, maybe several doctors or healthcare workers, and feel like they're not being heard?
I think change your doctor would be one piece of advice. So, for example, in my area of work, which is in menopause, we have a registry of all the doctors, GPs, who have an interest in menopause, and I would quite regularly direct a patient to